Hello and welcome to the Bronchiectasis Question Time webinar. My name is Kjell Hansen. I'm the chair of the European Lung Foundation, and this is just one in a series of events taking place around the world for World Bronchiectasis Day. And I'll mention a bit more about this later. But first of all, we have some housekeeping information I need to tell you about. So we do use an automatic translation app called Worldly. It's automated translation into 30 languages, and we have posted the link to the Worldly app in the chat box, or you can scan the QR code on the screen. When you access the app, you should first of all select the language that you want from the drop-down menu, and then click Attend. Worldly will open in a screen, and you can position it alongside the webinar to view both screens. You can read the transcript on your device or use a headset to listen to the audio. Automated translation is never perfect. Some words will be muddled, but we hope it will help. If you do have any problems accessing the app, then please email info@europeanlung.org, and a member of the ELF team will help you out. The webinar format is so that attendees can only see the host and panelists. We can't see you as participants, and everyone is on mute, so we can't hear you. We'll be asking questions that we have had submitted in advance for our esteemed panel of experts, and they will then meet in a moment and answer them. We also have two experts dedicated to answering questions that you put in the Q&A box in the bottom of the screen. So do put your questions in there during the event. If you don't have time to answer all the questions, then we will try our best to get the answers from the experts after the event and put these on our websites. Please remember that we cannot answer questions about anyone's personal circumstances or cases. After the event, this webinar recording will be made available on the ELF websites. It will take a few days, and you can freely access it along with people who didn't access the original webinar. We'll send the links in an email to everyone who registered for the event when it can be viewed, and also announce it on our other channels. Tomorrow is the 1st of July, and that is the World Bronchiectasis Day, a day that aims to raise global awareness, share knowledge, and discuss ways to reduce the burden of bronchiectasis for patients and their families worldwide. The COPD Foundation in the US has joined a global coalition of nearly 20 international organizations, including IMBARC and ELF, to bring awareness to this disease across the world. Do visit www.worldbronchiectasisday.org to find out how you can help us raise awareness, and there will also be a lot of information, resources, and more events that you might be interested in. If you use social media, then please feel free to tweet using the hashtag World Bronchiectasis Day and tag ELF, IMBARC, ERS, and the COPD Foundation using the Twitter handles that are shown on the side. I would now like to hand over to our question host for today, and that is Barbara Crossley.
Thank you, Kjell, and welcome to everybody watching and listening. We've had a fantastic amount of interest in this first Bronchiectasis Question Time, so I hope you find it useful. My name is Barbara. I'm from the UK, and I've had bronchiectasis since childhood. I'm now 71, so I am living proof that you can have a long, happy and active life, even with severe bronchiectasis, although I do work at it every day with physio and exercise. It's a condition as many of you know, characterized by abnormally wide and distorted bronchial tubes. In most cases, it produces excessive mucus, which is hard to clear. Unless we cough it up using airway clearance exercises, it becomes a reservoir for repeated infections that can make our condition worse. We've had over 250 questions beforehand, too many to ask our panel individually. So we've had to summarize and classify them into different themes. I hope you'll bear with us on that. As well as listening, you can also, as Kjeld explained, put written questions into the Q&A box, which will be answered by an expert behind the scenes. So now I'll ask our panel of experts to introduce themselves. First, our patient representative, Donna.
Hello, my name is Donna Heilweil. I was diagnosed with bronchiectasis when I was in my early 20s, but I believe I've had it since early childhood. I'm now in my 60s and I live with severe bronchiectasis in Switzerland. Most of my life was spent in the United States.
Thanks, Donna. Now the first of our clinicians, Georges.
Hi, everybody. I'm Josje Altenburg. I'm a pulmonary doctor from part of this ELF webinar dedicated fully on bronchiectasis. And I'll do my best to answer all your questions as good as I can.
And our other clinician is Tim.
Good afternoon, good morning, good evening for all the attendees here. My name is Tim Axamit. I'm a pulmonary critical care physician at Mayo Clinic in Rochester, Minnesota in the US, and just very glad to be part of this global collaboration and hopefully part of a very instructive and helpful webinar. Thank you.
Thanks, Tim. Our physiotherapist is Arietta.
Hello, Barbara, and hello, everyone who joined us today. My name is Arietta Spinu. I'm a respiratory physiotherapist, and I work as a lecturer and researcher at King's College London in the UK.
Thanks, Arietta. Our scientific researcher is Amelia.
Hi, I'm Amelia. I'm based in the UK at the University of Dundee, and I've been doing bronchiectasis research for over 20 years now, mainly scientific research in the labs.
Thanks, Amelia. And finally, our Q&A expert behind the scenes, Natalie.
Hello there, my name is Nathalie Laurent. I'm a respiratory physician at the University Hospitals Leuven in Belgium.
Thanks, Natalie. So thanks all of you. And now without further delay, I'll ask the first of your questions, which is about the causes of bronchiectasis. What are the causes, Amelia? And could it be prevented in some people?
Thanks. So bronchiectasis can be caused by lots of different things. So for example, it can be a result of having certain types of infections, either as an adult or as a child. It can also be caused by conditions which are related to inflammation. And a small number of people have genetic causes of bronchiectasis. When we look carefully at what causes bronchiectasis, in about 40% of people, we don't know and we can't find a cause, and we call that idiopathic bronchiectasis. If we can find a cause, I think it's important because in some people that cause is treatable. So for example, if you have your immune system doesn't work properly, there's sometimes that we can replace things that will help it to work better. So lots of different causes. We don't know about all of them, and some of them can be treated to try and stop progression of the condition.
Thanks, Amelia. The second topic that people asked a lot of questions on is airway clearance. And so I think we need to go to our physiotherapist and our patient representative for these. So, Arietta, is respiratory therapy or airway clearance important or crucial or just advice? And is it really necessary if you're stable with limited mucus?
Yes, so my answer to that, Barbara, is that it is crucial. And we know that from the way that the airway clearance works, based on the mechanisms that it affects our lungs. And we know from studies that airway clearance is much better than doing nothing or just coughing spontaneously. So we have very strong evidence that airway clearance should be practiced from patients who have secretions. When it comes to people who are clinically stable and they don't have lots of secretions, there is a need to practice some techniques to keep their understanding about the technique and keep their skills in a good state for when they need that. So for example, when they have an exacerbation and they need to use airway clearance, then they know how to do that appropriately. For the cases where they are clinically stable and they don't need a lot of airway clearance, of course, they don't need to use it daily, or it depends how much they would need to clear the secretions. So the frequency of practice of the airway clearance techniques can vary based on the individual and their symptoms. But the answer is that it's absolutely necessary.
And would you recommend that people use OPEC devices, those devices like the aerobica and flutter and a cappella that you blow into and vibrate, or even a vibrating vest? Would people find that beneficial? And what are the benefits of inhalers and nebulizing saline as well? If you could answer all of those.
Yes, okay. I will start first with the airway clearance technique. There's lots of options. So we can use techniques that people apply without any devices, or there are different devices like the one you mentioned already, the positive expiratory pressure devices with fixed pressure or oscillatory pressure, or there is the vest, which is a device that people put around their chest and create some vibrations to help mobilize the secretions mechanically. So basically apply force in their chest so they can mobilize the secretions to bring them higher so they can cough them up. We've recently conducted a European Respiratory Society statement, and we looked into the different devices and the different techniques that people can use in bronchiectasis. And again, we saw that we don't have evidence of one technique being more advantageous over another one. So all the techniques at this stage, we consider them that are almost equally effective. However, there are advantages and limitations depending on the technique. For example, if you have a device, you need to clear this device. You need to consider the size of it. If you need to get the airport to go somewhere, you need to think about things that about how you use this in your daily life. And we developed a table with advantages and limitations for each technique specifically, so people can go and refer to this document, which I think can be very helpful. And when it comes to the inhalers and for example, medications you can receive prior to the airway clearance techniques, or saline and hypertonic saline, then what they do, if you need them, is if you have bronchodilators, they open up the airways, so you can then bring the secretions up easier. or if they are cell line and hypertonic cell line, they help you to make the secretions thinner, especially if they are sticky and hard to move. And this way you can practice the airway clearance technique much more effectively.
Okay, thanks. What's going on if I normally can't produce much sputum, even with physiotherapy? I think some patients get confused because bronchiectasis is always characterized by excess mucus. And then when some patients don't have it, they think they must be doing something wrong. But there is a condition called dry bronchiectasis, isn't there? And I wondered if you could explain that.
Mm-hmm. So yes, I think we've started discussing about dry bronchiectasis much more often lately, and this is because we have patients who have reported that they don't bring up so much phlegm in their daily lives, so they don't have so many secretions as we thought. That bronchiectasis initially we were considering that is really characterized by these secretions of the most of the time where you bring up phlegm and you need the airway clearance techniques constantly. However, we know that there is a small group of patients who don't have that. So we call that dry bronchiectasis, which means that they don't produce so much secretions when they're clinically stable. So then when they're feeling well. And in this case, what I would suggest is that people need to be sure that this is indeed dry bronchiectasis, and it's not that the technique they are using is not effective. So it's not that there is something there that they cannot bring up, it's that there is nothing there. So that's why they don't cough up secretions and sputum. So if you don't have phlegm, that's fine. But if you have phlegm that you cannot bring up, then you need to see someone who can help you with specific techniques, such as the airway clearance technique. So I would say check with a respiratory physiotherapist if that's available in your country, or someone else who can advise you on that, because it's important to make sure that it's not something that you need to bring up and secretions that are staying within your airways.
Yes, thanks. I think the next question is for Donna. Actually, is airway clearance the best way to improve our quality of life, Donna?
Well, from my experience and from what I've heard from other people with bronchiectasis, there are many ways to improve quality of life while living with this disease. And airway clearance is probably at the top of the list. I would say that, as Arietta said, every body has different methods that will work for it, and you need to figure out what those are with the help of whoever you can get help from, and make sure to do them. I'm one of those people who produces ugly, sticky stuff very easily, and find that I need to do airway clearance twice a day. And when I'm feeling poorly, I increase the number of sessions per day, and that seems to really help get the mucus out. Mucus tends to hide in small little places in the lungs, and we have to do whatever we can to make sure that it gets out. And by doing that, we can decrease the number of exacerbations or flares that we have every year. It will also decrease the need that we have for any kind of medical intervention. And most importantly to me, it helps lead to a longer, healthier life. So it can be, doing the airway clearance techniques can be really annoying and uncomfortable and sometimes even a bit gross, but it's extremely effective and extremely necessary. And I strongly advocate that everybody do what they can to get that stuff out.
I agree with that wholeheartedly. Now we'll move on to a different topic, I think, which is exacerbations and infections and the consequence of those, which is antibiotics. So I need to talk to our clinicians, I think, as well as Donna. Thank you. So I'll address the first one to Tim. There is some confusion between the terms infection, exacerbation, and flare-up. Are they all the same, Tim?
And Barbara, that's a great question, and I'm not sure who's asked, or many of you maybe have asked that question. And the short answer is there's an overlap. And so in most instances, the bronchiectasis is characterized by having flares or exacerbations or increased symptoms intermittently. Those very often can be infection related, but not strictly only infection. So that's something over a period of time oftentimes will be further discriminated with you and your providers and physicians to sort out, are there infections all the time, or are there other potential contributing factors to that? And to follow up, it just to have this concept that there's a very heterogeneous component to bronchiectasis, as was mentioned for causes of bronchiectasis, as well as treatment approaches, so that this has to be very individualized based on patients. You know yourself better than anyone else. And although that there are similarities that you may find when you talk with colleagues or friends or providers, sometimes there are unique features in your particular case that need to be addressed. So again, I just can't emphasize enough that this should be an individualized approach. When you have symptoms that increase, we generally, from a research standpoint, have somewhat arbitrarily defined that as 2 or more days of increased sputum or feeling unwell with a fever or coughing up blood or having an increased amount or darkness of sputum. Those are the kinds of indicators that often reflect that there is a flare or an exacerbation going on. How you approach that then is really something that it needs to be discussed with your physician as far as what's best to do, either antibiotics and or other interventions. And just to emphasize in this regard, and what Barbara had touched on, is that bronchiectasis is, again, a manageable condition. Although it's not curable at the moment, it is manageable, and it needs to be, again, individualized to each one of you to find out what works for you. Those possibilities and the resources available are on the EMBARC site, on the European Lung Foundation site. There are other global partners in the Australian Lung Foundation and the Bronchiectasis Toolbox. There's a US site called the Bronchiectasis and NTM Initiative site. So the point in this information will be shared with all of you on how best to approach this. But again, remember, this is individualized, and the best approach is what works for you as a patient.
Thanks, Tim. Now perhaps Josie can answer this one. Why do some patients manage a flare-up with a rescue pack of antibiotics and sometimes even steroids, and others manage it without them? What makes the difference of whether you get a rescue pack or not?
Yes,
and for those who don't know what a rescue pack is, it's having a supply of antibiotics in the cupboard at home, just in case you get an infection or an exacerbation and you can't get a prescription very quickly. So it's an emergency pack, basically.
Yes, thank you, Barbara. I think this is another great example of the heterogeneity of bronchiectasis. So not every person with bronchiectasis is the same, and not every infection or exacerbation is the same. I think in general, it's important that if you are a person with bronchiectasis who has a lot of bacterial infections and exacerbations, I think in general, it's wise to treat them quite quickly with antibiotics and not wait too long until the symptoms have gotten too bad. But there are also people with bronchiectasis who, if they have a slight increase in symptoms, they can reduce them with doing extra airway clearance techniques or taking more care of themselves, and then the symptoms will go away again a little bit. So I think the people who need a rescue pack would be the patients with bronchiectasis who have severe bacterial infections. And what's more important, that your doctor knows which type of bacteria you have. Because there's a lot of people with bronchiectasis who have the same bacteria over and over again. For instance, a Pseudomonas is a bacteria that can remain in your lungs for longer periods of times or even accompany you your whole life. So it's important that you know which type of bacteria you have and that your doctor knows. So your doctor is probably asking you to hand in sputum every once in a while to check that. And as they know which bacteria you have, they can give you this rescue package directed specifically to that bacteria. If you have...
Oh, Josie's signal's just broken up there.
Different bacteria.
Sorry, Josie, your signal is breaking up. Perhaps we can go to a different question and it might stabilize. If I can address this question to Donna, how do you feel about taking repeated courses of antibiotics? Do you worry about antibiotics, Donna? You're muted, I think.
How's that? Working?
Yeah.
Excellent. So I myself have been through the mill with antibiotics throughout my decades. Oral antibiotics, intravenous, inhalations. Quite frequently at times, there was a few years when I was only having about a week break between 2-week courses. And I only developed any antibiotic resistances very recently once I became colonized with Pseudomonas. So I think if you're sure to take the full course of antibiotics as they are prescribed, rather than, as some people might be inclined to do, to stop treatment once they're feeling better, if you keep with the entire 14-day course, then you are less likely to be developing resistances with time. I also find that taking most antibiotics can be quite unpleasant, and there will be side effects, different ones for different antibiotics at different times. It might impact you differently, but I think it's really important to keep in mind that if you tolerate the side effects and realize that it's something that will go away once you're through the medication course, that you are in fact doing the best you can to bring about your own best long-term health, and that it's a necessary inconvenience, but just try to tolerate, put up with it, and know that you're doing well for yourself.
It can be more than an inconvenience. The treatment burden of inhaled antibiotics and intravenous antibiotics is pretty high, I think. Yes, you really have to be committed to those. And I do worry about antibiotic resistance. And I take azithromycin long term. I take it every day, and I worry about the effects of that and whether there might be any long-term effects. We just don't know. So Tim, should we try to avoid the need for antibiotics as much as possible?
And that too, Barbara, is an excellent question. And as has been already pointed out, there's not a right or a wrong answer. That is to say, we want to be responsible stewards of usage of antibiotics and find what essentially is a sweet spot to use antibiotics when they're needed, but not in an excessive amount to potentially develop resistance. And whether we use antibiotics for bronchiectasis or other infections, whether it's as an outpatient or an inpatient, the more we use antibiotics, the more resistance is likely to develop. So again, the point only is to use antibiotics when necessary, but to try to avoid that. And one of the tools or approaches is, again, with airway clearance and attention to other wellness issues, is trying to minimize the number of flares or exacerbations so we don't have to take antibiotics unless necessary. And as was pointed out by a previous speaker, that it's helpful to us as clinicians to understand what the germ or germs are that are present that may be the culprit as far as a flare or exacerbation goes, and as pointed out by Dr. Altenberg, Pseudomonas. But we also understand that there are many other germs and bacteria and other types of germs, including mycobacteria, that can sometimes be part of this whole milieu. And so using the correct antibiotic is as important as using any antibiotic. And again, trying to then mitigate the number of exacerbations, yet using the right antibiotic at the right time and not making otherwise simple situation more complicated. I'm going to ask my colleague, Dr. Altenberg, who has great expertise in a group of medicines called macrolides or azithromycin, as you talk about, Barbara, that in some instances, if there's a mycobacterial germ present, an NTM, non-tuberculous mycobacteria, or most commonly MAC, M-A-C, Mycobacterium avium, we try to avoid using monotherapy. And with that, I think if Dr. Altenberg is available, I would have her comment on the macrolide use in this context of trying to be responsible stewards of antibiotic exposure, but also keeping things in check and controlling things in the spirit of managing bronchiectasis. Dr. Altenberg, are you available?
I think we may have lost her for the moment.
I see.
Or maybe we can come back to that.
Fair enough.
Yeah. Okay. Because there is a question that's possibly linked to those infections that you mentioned, non-tuberculous mycobacteria, NTM, and Pseudomonas, which is does inflammation in the lungs affect the whole body? Does it show up as a high blood cell count, high white blood cell count, or do overall damage to cardiovascular health?
Yes, so we understand based on some research, and I will ask my colleague Amelia to also comment on this, that the infections or inflammation that occurs with these infections in the lungs does have an impact or can be detected systemic wise, that is at other places in the body. And one of our approaches is to try to modulate that or intervene to make sure that patients have shorter courses or even can prevent some of these flares in some instances. I might also add, and it gets complicated in the pack that you talked of, Barbara, about the rescue pack of antibiotics with or without steroids, steroids meaning cortisone, prednisone, salumedrol, one of those types of steroids, which generally reduces inflammation. We think that steroids in general don't help us get over infections or aren't necessarily important for bronchiectasis as such. But as was pointed out, I think in the chat box and maybe one of the questions, for those individuals that have asthma or other indications that need steroids, that's a crucial component to an effective treatment strategy to not only use antibiotics, but steroids. But for many other patients, we want to avoid those steroids. So we have to, again, individualize this in a way. And maybe I can ask my colleague, Dr. Schomark, Amelia, to comment about that systemic inflammatory response that has been identified with the research that she's participated in. Dr. Schomark.
Yeah, so like everything else in bronchiectasis, I think the inflammation can also be heterogeneous. So you can have different types of inflammatory cells that are seen in your blood that are raised, different types of white cells, and they probably need to be treated differently. The best place to see the inflammation really is in the sputum and what you're coughing up, if you're able to do that. And it's the inflammation that makes the sputum green, for example. So the more green your sputum is, the more likely you are to have some inflammation. But the blood can be a good place to also see that, and maybe to help guide treatment as to what type of inflammation it is.
Maybe this is a good point to mention the research that you're doing on drugs that might reduce inflammation, Amelia.
Absolutely, yes. So there's lots of new drugs in the pipeline for bronchiectasis. In the past, we've concentrated a lot on antibiotics, and there are still antibiotics being trialed in bronchiectasis. But one of the more exciting areas of finding new therapies is inflammation. And there's a few different drugs, some of which are successful in asthma, for example, which are being tested. But there's also drugs against neutrophilic inflammation, so the inflammation that makes your sputum green. And that class of drugs are called DPP1 inhibitors. And there's a couple of different drug companies doing trials into them at the moment. The first trials in DPP1 inhibitors have shown that they can prolong the time between people having flare-ups. And that's important because if you prolong time between flare-ups, then that can ultimately, hopefully, slow down disease progression. Some of those trials are now in phase 3, and phase 3 means is essentially the last phase of clinical trials. So if they're successful, they will be hopefully coming to the clinic in not too distant future if those phase 3 trials are successful. So that's a really exciting, I think, hope for the future for treatment of inflammation in bronchiectasis.
And I might just add on to that the recurrent theme here is that the 3 pillars or legs of the stool of bronchiectasis of infection, inflammation, and mucus are all important. And so we need to address each one of those components, as Amelia is talking about, the inflammation that goes along with this, the infections when they're present, and as well as the mucus, not only from a clearance standpoint, but then modification of that. And that also brings me a segue, and I see Dr. Altenberg is back with us to comment on the macrolides. I had raised that in trying to avoid that monotherapy in those with NTM disease, but the positive contribution and role that macrolides have in other bronchiectasis patients. Dr. Altenberg.
Yes, I'm back. I hope my connection's better now. Yeah, I think there's a lot to say on the subject of macrolide antibiotics. I think there will be among the participants quite a lot of people who use long-time macrolide therapy because in severe bronchiectasis, so in patients who have many exacerbations each year, it can be a very useful treatment modality. And the idea behind it is that macrolides don't only act as antibiotics, but also have an anti-inflammatory mode of action. So they directly modify the inflammation that people with bronchiectasis have in their airways. And if you look at the studies we see that who use macrolide long term have less exacerbations, but also have a reduction in sputum and therefore a better quality of life. But it's important to say that, again, with this therapy, it's not for everyone. If you have certain bacteria in your lungs who can become resistant, just as Dr. Aksamit mentioned, the NTM bacteria, it's not a good idea to take them, at least not as monotherapy. And also, if you have only mild bronchiectasis, it wouldn't be the treatment choice that you get firstly, because it has some side effects and it can also attribute to antibiotic resistance issues. Although it's important to say that even when we looked in the studies, even when patients developed resistant bacteria, the antibiotics still worked, which indicates that it's foremost the anti-inflammatory mode of action that makes patients feel better. So there's no need to be overly concerned about resistance issues in this treatment.
I think macrolides are really good, evidence that that treating inflammation in bronchiectasis works.
Oh, well, that's good to hear. I'll keep taking them. On the subject of drugs, some people have asked about natural ways to thin mucus. Are there any that perhaps you are aware of, Arietta, to thin the mucus rather than using drugs like Mucilex and carbocystine?
Yeah, so the best medicine that is natural, I would say, is water.
Water?
So we know, yes, water. So we know that our secretions in the lungs are made up about 95% from water. So that means that if they are dehydrated, we need to help them move by helping the hydration of the secretions, basically. So helping our phlegm become thinner, and drinking water is helping us, first of all, like in every part of our body, this would help hydration. But then this extends to how we use nebulization or ultrasonic nebulizers, hypertonic cell line or normal cell line, which what we are trying to do is help our the layer that lies our airway, so the tubes of the lungs, to become to get more water. So I think water is a good option in the starting point. So if people find that their phlegm is sticky and it's hard to move and it feels like it's stuck somewhere, first of all, drink some water, and then let's think about other steps.
Can I add something else? I think another great natural way of getting your phlegm up is exercise, which really helps bring in. Most of the time it's used in combination with airway clearance techniques, but I find that a lot of patients really benefit from exercising regularly, and then the type of exercise that really makes your body move, so the secretions can come up much easier. And I think it's also good to realize that the saline that a lot of patients are using is also quite natural, right? It's a natural agent.
Yeah.
Exactly, yes. So definitely exercise for all the benefits that it can offer us, but also to help with airway clearance. Usually when you exercise, you would still need to do some type of airway clearance technique. So just to make sure that you bring up the phlegm that has been moving within your lungs, but it's definitely very helpful.
And I might just piggyback onto those comments and reassure many of the attendees that exercise really refers to activity in a spectrum. We're not training for the Olympics, so that many of us who have a hip or a back or a knee problem, sometimes that exercise or activity may be just doing yoga or Tai Chi that is accommodating to our musculoskeletal limitations. Most of my patients walk, some ride a bike, some do other levels of activity, and Arietta can talk of this, but just to reassure our patients that what we really want you to do is keep moving and be active. And whether that's yoga or Tai Chi or more intense activities, we're not exercising to the extent of training for Olympics. So please be reassured that just being active and moving is the first portion or first step, no pun intended, in that direction. And Arietta, I'll let you expand on that. Thank you.
Yeah, I think
if we could, I'm just conscious of the time, and there is another topic that causes quite a lot of concern for people, which is what doctors know as hemoptysis, and what we patients know as blood in the sputum. So it does cause anxiety. when it happens, although it is common with bronchiectasis. Can any of you address what causes blood in the sputum, and can it be avoided? Tim, would you like to?
Sure. So this is a very important question, because when this occurs, this gets our attention. This isn't, gee, I just don't feel well. This is, and sometimes the bleeding is relatively mild in a few flecks of blood. Sometimes it's streaks of blood, and sometimes it's more clots, and we call massive, which can be potentially life-threatening. In most instances, if patients start coughing up large amounts of blood clots in a different way than they do normally, if they've had that in the past, to seek medical attention immediately would be important. It doesn't happen often, but at times can be life-threatening. To answer your question, Barbara, about why does this occur, we think that that dilation of the bronchial tubes that is so characteristic of bronchiectasis has small little blood vessels in those dilated tubes, and that with irritation, whether it's an infection, inflammation, or another reason to break those small blood vessels, that sometimes then the bleeding will occur. It often is associated with an infection, but not always. And in the most severe instances, then life-threatening, that bleeding can be stopped either with medicines, this TXA, it's a medicine that can be taken either orally or inhaled, or can sometimes even the radiologist will go in and with a catheter, if it's a very life-threatening situation, go into the blood vessels that are supplying that area of the lungs and plug those blood vessels with coils. We call that embolization. So again, the hemoptysis is along a spectrum, like so much of these aspects of bronchiectasis, sometimes mild, sometimes not something to be concerned about, and other times can almost, well, can be life-threatening. So if there is bleeding that occurs, I would encourage folks to, again, talk to your physicians about what your plan is. What do I do if the bleeding occurs, and how much? Is it a few flecks of blood that come and go intermittently and regularly, or is it something that's more substantial than that, or something in between? And I'll defer to Dr. Altenberg as well on other thoughts.
Yes, I completely agree with you, Tim. I think you already said a lot about hemoptysis. Maybe I missed it because of my connection, but did you mention tablets that might thicken your blood a little bit and then stop the bleeding?
Yes, I think he did. A tranexamic acid tablets, isn't it?
Okay.
TXA. Yeah, that's good.
Can I add something for the hemoptysis from the airway clearance point of view, Barbara? So if you have hemoptysis and it's very small and it's not something that you're worried about, you can continue your airway clearance technique as normal. But if it's something more unusual, a higher amount of blood, and you're worried about it, you shouldn't continue if you're using positive expiratory pressure devices. So airway clearance techniques in these cases we do are the gentler forms of this, and we don't use positive pressure until we have stability from the hemoptysis side.
But if you're just managing it at home, what would you recommend? We just do more relaxed airway clearance exercises?
I think be slightly more gentle. If it comes to being something more abnormal, if you have usually a bit blood of in your phlegm, and that has happened before, and that's quite normal for you when you have an exacerbation, there's nothing to worry about. I'm talking about when there is a change, and then that means you need to change your plan with your respiratory physiotherapy as well.
Right, thank you.
Can I add just a little bit more? I think it's very important that, of course, you have to be cautious with coughing up blood, But if it's something that you're used to have and it's only a little bit, then it's important not to completely stop your airway clearance techniques, because I see that a lot. Of course, it's a frightening sight sometimes when you cough up a little bit. The patients stop using their airway clearance and they get into an exacerbation. So I think that it's an excellent advice just to take it down a notch, to use the milder techniques until the bleeding goes away.
Okay, thank you. And I'm sorry, we're really up against the time limits here, so I'll just have to go to the last question, which perhaps all of you can say a little bit about. Do you foresee a time when bronchiectasis can be cured?
Shall I go first?
Please.
I think the ultimate goal is prevention rather than cure, actually. So I think the best thing that we could do from a research point of view is try and prevent bronchiectasis from happening in the first place. And to do that, we probably need to know more about the causes and what's causing it, which we're slowly beginning to understand, but also to understand what's happening in the lungs in terms of the infection, the inflammation, and also the mucus. So doing studies into that and trying to catch people that have lots of infections before they get the scarring of the lungs and before they develop bronchiectasis, to me is the best sort of research goal for the future.
Tim, what about the cure? Is it on the horizon?
I think it is on the horizon, and I'm encouraged, but not ready for prime time. As you pointed out at the outset, Barbara, this is, and Donna as well, this is a manageable condition. And so I think having an awareness that it's present, what those contributing factors are, either other diseases or other contributions, are really important. So the other thing that had not been yet mentioned is sometimes outside the lungs, if there's active sinus disease, sinus infections, or significant gastroesophageal reflux disease, swallowing problems, that too can exacerbate lung conditions, including bronchiectasis, and needs to be addressed in this context. And so, although there's not cure available, what I tell patients is that in most instances, from a long-term standpoint, are we going to potentially die from the bronchiectasis? And then what I tell patients is you're going to die with it, not of it. So it's manageable. And again, witness Barbara and Donna and patients that have this condition. That's the good news. The downside is it does require attention. And just as you pointed out, again, aptly, Donna, early on, you've done this all your life and been very effective, and your hard work is paid off. And that opportunity is available for each one of our patients with bronchiectasis.
Thanks,
Yes,
Tim.
I completely agree, Tim. And I think I'm actually quite hopeful about the future of bronchiectasis. If I look back, let's say 15 years ago, when I started in the field of bronchiectasis, there was actually hardly any research, hardly any recognition of the disease. There were a lot of pulmonologists who didn't really know what bronchiectasis was or didn't really know which causes to look at. And I think we made a great amount of steps towards cure or improvements in bronchiectasis. And especially the new treatment modalities that are tested that Amelia talked about, the anti-inflammatory treatment, I think that really gives a lot of hope for patients with bronchiectasis nowadays.
Thanks, Josie. And Arietta, what are your thoughts on the possibility of a cure?
Yeah, I will echo everything that previous speaker said, especially when it comes to the new medications. And I think the example with the recent example of cystic fibrosis shows us that when there is the right targeting in terms of the medications and the personalized medicine, how it can transform people's life. And it has changed respiratory physiotherapy a lot in terms of how we treat people with cystic fibrosis. So I do hope that at some point we are going to see something to the similar extent to bronchiectasis. But until then, I think we definitely have done lots of work in the last years, and especially in the side of management and self-management as well. So there's been lots of promising studies about how can we live with bronchiectasis, live well, and what can people do for themselves.
Thanks, Arietta. And Donna, does that do wonders for your mental health, knowing that there might be cures or improvements at least on the way?
Certainly. It's always nice to be optimistic and to think that people who are coming through the pipeline, just starting in their lung disease journey, might have a very different experience than us on the older end might have had. I think that would be an amazing benefit to people who have this chronic disease. I also wanted to say, I have no personal qualifications to address whether or not there's going to be a cure. But what I can say very assuredly from my own experience is that when one lives a healthy lifestyle, not just focusing on bronchiectasis care, but having good nutrition, good sleep, taking care of the body, taking care of mental health, remaining active as much as possible with the body, with the mind, being socially engaged on a regular basis, that even living with this chronic condition, one can lead a very meaningful, joyous, and fulfilling life. And I wish everyone the best on their own journey. Find your own personal solutions and be proud of everything that you're able to do for yourself.
Thank you so much to everyone on our panel, and to Natalie behind the scenes, who's doing sterling work answering the questions, the written questions. So thank you, everybody. We haven't been able to address all your questions by any means, but there are plenty of sources of information online, which will be shown on your screen shortly in a slide. I'd particularly like to draw your attention to our new bronchiectasis self-care guide, produced by patients in collaboration with physicians, which is being launched tomorrow on World Bronchiectasis Day. It'll be available on the europeanlung.org website, that's right. So I hope you find all that useful. And I'll now hand back to our chairman, Kjeld Hansen. Thank you.
Thank you very much, Barbara, and thank you to all who participated in this webinar. Even though we haven't answered all the questions, then I hope that we have managed to answer the most important ones. But if there are questions that we have not answered, then we will aim to post them also online. And we will also guide you on this slide to where there's a lot more information, resources available online for you to find out. So see our slide for links, and we will also include these links in our follow-up mails from Eventbrite, which will have a link to the feedback form, so you can tell us how you think this question time event went. Here are just some of the bronchiectasis resources that you can access after today's events if you want to search out more information. ELF does have a bronchiectasis website with more information about treatments, airway clearance videos, and lots more. It's available in English, French, and Dutch. You may also have attended one of the annual bronchiectasis patient conferences, and recordings of these presentations by clinicians and patient experience videos can also be found on the ELF website. And as Barbara just mentioned, we are launching a new bronchiectasis self-care guide written by people with bronchiectasis to share what works for them. We are launching this tomorrow on World Bronchiectasis Day, and you may download it from the ELF website. The COPD Foundation's Bronchiectasis and NTM initiative has a webinar series too about feeling your best with BE, as well as a toolkit and information sheets in multiple languages. The COPD Foundation were the ones who instigated World Bronchiectasis Day, and Lung Foundation Australia has produced a bronchiectasis toolkit full of useful information as well. Finally, I want to say a big thank you to our panel of bronchiectasis experts. We have Donna, Tim, Amelia, Arietta, and Joshe. To our expert clinician who have answered your questions in the Q&A box, Natalie, and to Barbara for hosting and asking all the questions so well. The EMBARC Steering Committee have been very helpful with their guidance and support, and the ELF Bronchiectasis Patients Advisory Groups have been very helpful with planning, and also the planning group have done that. Everyone who joined us today, thank you so much for taking part in this event. Remember that the talks have been recorded, and we aim to get them out on our website next week. So we'll notify all delegates by email. You might also see that we have a donates function. So if you want to see more bronchiectasis and patient events in general, please consider donating so that you allow us to build even more events for the future. Have a great rest of the day, and I hope you can help with raising awareness for bronchiectasis with us tomorrow on the World Bronchiectasis Day. Thank you very much.
Thank you. Bye-bye.
Thank you. Bye.